My talk is on approach to the systemic venous system. This is a complicated topic, so I'm going to try to simplify as much as possible and give you really the highlights and what to look for in your evaluation. For disclosures, I'm on the advisory board of these companies listed here. So I'm going to review the normal systemic venous anatomy. I'll share with you a stepwise approach to the evaluation of the fetal venous system, and I'll review some venous abnormalities that are pertinent to your day-to-day evaluation. So if you look at the venous system in the fetus, you see the umbilical vein coming in, giving a branch to the ductus venosus that angles up towards the area called subdiaphragmatic vestibulum here, connected by the portal venous system, the IVC, and the hepatic veins. And then you see the coronary sinus draining the heart into the right atrium, the four pulmonary veins into the back wall of the left atrium, the azygos vein, which was discussed really nicely today, and then you have the SVC that is formed by the left brachiocephalic vein that drains from the left side across into the SVC and the SVC itself. So you've seen images of the aortic arch here, and this is, if you move a bit to the right parasagittal, you see the azygos arch draining into the IVC right here. Blood flow is towards the heart, red here, blood flow away to the heart. Now, I'm going to follow this paper that was published in 2013. It's in your syllabus about a systematic approach to the evaluation of the fetal venous system. So I'm going to primarily focus on the axial planes, looking at the portal and the hepatic venous circulation, looking at the coronary sinus, and then the azygos, SVC, and the left brachiocephalic vein. I'm going to skip the pulmonary venous system, which will be discussed in a separate presentation. So let me spend a bit of time on the venous portal system. So the term portal system defines veins that don't go towards the heart. And there are two portal systems in the body. There is the hypophyseal portal system. This is where blood goes from the hypothalamus to the pituitary to inform about the endocrine environment. And then there's the hepatic portal system, where the drainage from the GI tract goes to the liver to really bring the nutrients, but also clear the GI tract, the blood, through the liver before it goes into the systemic circulation. Let me share with you the blood flow to the liver and comparing prenatally and postnatally. So if you look at the liver prenatally, there are three main sources of blood flow. The placenta through the umbilical vein is the main source of blood flow to the liver prenatally. The hepatic artery, a branch of the aorta, brings about 25% of the blood flow to the liver. And the GI through the main portal vein, both the splenic and the splanchnic veins come together. That contributes very minimally, less than 5% of the blood flow to the liver prenatally. The drainage of the liver is through three hepatic veins that drain into the IVC, right, middle, and left hepatic veins. If you look postnatally, the main source of blood flow to the liver is now the main portal vein. And that contributes to the majority of blood flow to the liver, about 75% of blood flow, and is joined by the hepatic artery that brings about 25%. Clearly, there's no umbilical vein postnatally, so there's no contribution into the liver. The drainage of the liver is no different than in the fetus with the three hepatic veins that drain into the IVC. So this is a schematic drawing that shows the descending aorta with the hepatic artery that, as I mentioned, this is prenatally, that contributes about 25% of blood flow. Here's the umbilical vein coming into the liver, and that brings about 75% or so of the blood flow. The splenic vein and the mesenteric vein drain into the main portal vein, typically under the liver and typically not seen prenatally, but it could be, especially if it joins in an X configuration to the portal venous system. So here's a schematic drawing of the main portal vein coming into the liver. This is a postnatal image. You see all the venous drainage coming in. And this is a schematic drawing of the drainage of the liver with the right, middle, and left hepatic veins. So the idea here is the blood comes into the liver, and it goes into the tissue of the liver, and then is drained through the capillaries into the venous system through the right, middle, and left hepatic veins into the IVC. And here's the vasculature postnatally. What happens postnatally is the contribution of the main portal vein actually results in reversal of blood flow within the portal venous system, because now there's no umbilical vein, so the blood comes from the main portal vein in a reverse direction into the portal system. Drainage is no difference, and as you know, the ductus venosus closes postnatally. Now, to show you that these two circulations and how they are related to each other, you see this is the portal venous system, right? So this is the umbilical vein coming in, and here's the portal vein, and that's the ductus venosus. And this is the hepatic drainage right here. And here's again is the ultrasound, corresponding ultrasound image of the left portal vein coming into the portal sinus. This is a bit higher, showing the hepatic drainage. And look where the ductus venosus is. The ductus venosus actually is the link between these two circulations. And the ductus venosus, in its orientation, is directed upward towards the heart. So if you look at this from a schematic drawing, this plane at the level of the umbilicus, where the umbilical vein comes in, shows you the portal venous system. Again, I'll go through those in a bit more details. And this plane, which is a bit higher, is actually the hepatic drainage, right, middle, and left hepatics into the IVC. So if you look at the anatomy of the portal venous system, you have what's called the left portal venous system. The left portal venous system is the umbilical vein that's inside. As soon as it's inside the liver, it's called the left portal vein. And the portal sinus is actually part of the left portal vein and gives rise to three branches: midline branches, inferior and superior branches, as you see right here. The right portal vein is in the right side of the liver, is a continuation of this left portal vein, and has a posterior and anterior branches. And you see the main portal vein that's coming from under the liver into this configuration. And here's what you see on your ultrasound exam. This is at the level of the abdominal circumference. You see the umbilical vein coming in. So that's the left portal vein now up to here. This is the portal sinus, is part of the left portal vein. Here's the three branches, 1, 2, 3 that I've talked about. Ductus venosus coming as an offshoot anteriorly towards the heart. And here the branches on the right side, right inferior and anterior and posterior right portal veins. Again, left, right, ductus venosus. And the main portal vein is under. In this ultrasound image, you don't see it really well. And here's another corresponding image where the spine is on this side. You see the main portal vein coming in. Again, this is with technology to show you the capillary flow. You see the branches of the left portal venous system here. You see the ductus venosus here. And this is the right portal system right here. So it's the same vessel, the umbilical vein, that goes inside the liver, that is defined as the left portal vein at its origin, and then as it curves to the right side, becomes the right portal venous system. Hepatic drainage, if you move a bit up into right under the diaphragm, you see the right, middle, and left hepatic veins that are drained into the IVC, as you see right here. The left hepatic vein is the larger vein in the fetus, just because it is the left lobe of the liver is large. Why? Because the portal venous system has the highest oxygen content. As it gets into the liver, it really expands the left lobe of the liver that gets smaller after birth. And here's a 3D image showing you the umbilical vein under, and the ductus venosus connecting the umbilical vein with this area that's called subdiaphragmatic vestibulum. That's the heart right here. And these are the three hepatic veins draining. And again, what you see here, that's the portal venous system, and that's the hepatic drainage in a bit higher level. The ductus venosus, as you could see, you see it as typically aliasing in an axial plane, because it narrows, because the portal sinus and the left portal vein narrows into the ductus venosus, so there is acceleration of flow resulting in this aliasing here. And if you're in a parasagittal view, you see the umbilical vein coming in, And look at the orientation of the ductus venosus. It's going towards the heart, and I'll come back to that. This is an important finding. And then aliasing is really critical, and that's the middle hepatic vein joining them into this area right below the heart. And here's the ductus venosus, as you see, its location in an axial plane. So let's go through some abnormal findings of the portal and the hepatic venous system. I'm going to cover those to give you some perspectives of what you expect to see in your day-to-day scanning. So first is a persistent right umbilical vein. So the clues to diagnosis here is that the left portal vein, as it comes into the liver, and its portal sinus turns to the left side rather than turning to the right side. And typically the gallbladder is seen to the left of this left portal vein. And you see in the schematic drawing also the abnormal curvature. So here's another example right here. So these are typically normal variants if everything else is normal. So typically we do a detailed ultrasound. If there are no other associated findings, we consider them a normal variant, maybe a follow-up ultrasound growth in the third trimester. In a large series, 75% are normal, probably a bit more biased because of the identification probably related to other anomalies. So a detailed ultrasound and a follow-up ultrasound is probably everything that needs to be done in this situation. Now, umbilical vein varix is actually a dilation of the intra-abdominal extrahepatic umbilical vein. And you see it right here. So this is the umbilical vein before it goes into the liver, is dilated and ballooned, as you see here. Typically, it's a visual inspection. You see dilation, you make the diagnosis, but there are some objective criteria. If it is more than 9 millimeter or greater than 50% of the diameter of the intrahepatic segment. So either of these two. There's some correlation with fetal growth restriction and demise, especially for large sizes. If you have a varix as big as this one, I think this warrants more close observation and follow-up. Probably every 3 to 4 weeks follow-up growth and maybe some fetal surveillance in the third trimester. An important feature to look for are the connections of the umbilical vein. So this is a parasagittal view. I wanted to show you this to show you the umbilical vein coming in. So here's the umbilical cord right here, right? So here's the arteries coming back up into the cord. Here's the umbilical vein coming in. Look at the direction of the umbilical vein, and look how it narrows here, and there's a bit more aliasing, and look at the direction of this. So what I want you to see is really this. Here's the umbilical vein direction, and here's the ductus venosus. So two important things to note here when you look at this view. One is the ductus venosus is smaller in caliber than the umbilical vein itself. That ensures that there is a ductus venosus. Two, the orientation of the ductus venosus is upward towards the heart. That's another important feature. So there could be many different configuration of abnormalities of the ductus venosus. So here's the normal one right here. Again, as I've described it, narrowing and angling upward. Here's no ductus venosus, agenesis of the ductus venosus. Here's the ductus venosus actually connects to the IVC, does not go upwards towards the subdiaphragmatic region right here. Here's no ductus venosus, but the umbilical vein connects to the IVC. Here's the umbilical vein goes straight to the right atrium, as Elena showed you in the case report this morning. It could be either the right atrium or the coronary sinus. And here's the umbilical vein actually going to the pelvic veins through the iliac veins and coming back to the heart through the IVC. So there could be any different combinations and permutations of this. So here's the normal orientation. Aliasing right here, typically you have a different color because of the aliasing within your ductus venosus. Again, look at the narrowing and look at the orientation of this vessel. No ductus venosus here. Here there is narrowing, so I'm diagnosing a ductus venosus, but it's connecting to the IVC rather than it's connecting to the subdiaphragmatic region. There is no narrowing of the umbilical vein, so there's no ductus venosus, but it dumps into the IVC. This is going into the right atrium, and this is going into the venous to pelvic system, and I'm showing you a dilated IVC returning the blood because of the increased blood flow to the iliac vessels. Here's an umbilical vein to the pelvic vessel. So here's the umbilical vein coming in. Here's the arteries right behind it. It's going to the iliac vessels, and it's returning up through to the IVC right behind. And then look at the dilation of the IVC, in this case, coming back to the heart. Here's an umbilical vein to the right atrium. Again, you see the dumping right into the right atrium. And again, you see it in different views. Here's an umbilical vein going to the coronary sinus. Why do I know this is coronary sinus, not right atrium? Because the coronary sinus is dilated, as you can see right here. As you go a bit inferior to the four-chamber view, you see the coronary sinus, and it appears dilated. So these are the different, it's easy to make the diagnosis once you understand the normal anatomy and where the umbilical vein, typically they're dilated and there's a lot of aliasing on your imaging, kind of suspecting the diagnosis. Let me talk a bit about the portosystemic shunt, because this is a fairly common diagnosis that could be difficult to make or confusing a little bit. The term portosystemic shunt means that there's a direct connection between the portal veins and the systemic veins, bypassing the liver tissue. Remember what I said, that the portal venous system brings blood to the liver tissue, and that is drained through capillaries and venules into the hepatic drainage. If there's direct anastomosis between the portal veins and the hepatic veins, that's called the portosystemic shunt. This could be extrahepatic, difficult to diagnose prenatally, or intrahepatic. So here's the normal anatomy that I've shown you earlier. So what do you see here? You see a direct connection between the left portal venous system and the left hepatic vein. So this is the left portal vein to left hepatic vein portosystemic shunt, right? This is a right portal vein to the right hepatic vein. Now this is an extrahepatic that is partial, meaning there is some communication between the main portal venous system and the IVC, as you see here, but you still have some circulation. And this is a complete extrahepatic portosystemic shunt. The whole drainage from the main portal vein goes to the IVC. This you can diagnose prenatally because you put color Doppler at the abdominal circumference. You don't see any developed portal venous system. And that's very rare, but that's how typically these diagnoses are made. So here's an example of a left portal vein to left hepatic vein. So follow me here. Here's the umbilical vein coming in. Here's the portal venous system. And look at these branches, the two branches that I mentioned to you earlier of the left portal vein connecting directly with the left hepatic vein. Look at the size of the left hepatic vein draining back into the IVC. And there's the inferior view at the level of the portal venous system, showing you these dilated inferior and superior branches of the left portal venous system. And this is a bit higher, showing you the drainage of the left hepatic vein into the IVC. Here's another example. On grayscale, this is what you see. You see some dilation within the liver. You're thinking, okay, is this a hemangioma or anything like this? You add color Doppler, and you see again the left portal venous system draining into this area here. And you could see how dilated these vessels are. And look at the left vein, the blue one, connecting with the IVC. Here's another example of a left portal vein to left hepatic vein. This is a different view on grayscale. This is what you see. But look, they look the same, right? Here's the umbilical vein coming in. Here's the portal vein. And look at the drainage. And this is what you really see. The portal venous and the hepatic venous are connecting together, bypassing the liver tissue. And just get a memory burn of this, because the most of those are left-sided, and this is really what you see on ultrasound. And this is a right portal vein to a right hepatic vein. Again, it's the same concept. And you see here the right portal venous system connecting with the right hepatic vein into the IVC. And you see it right here on color, just a direct connection where the aliasing is between the two systems. And here's another example right here of a right portal vein to a right hepatic vein. It could get complicated. This is a hepatic artery that is draining to the left portal venous system. So if you look, there's a vessel that's coming up from the liver and connecting with the left portal vein as it comes here, and you see it right here, and that's the artery. You see the spectral Doppler of this vessel right here. So all these are portosystemic shunts of different types. Poor prognosis based on my personal observation. If you have any cardiac or extracardiac abnormalities, if there's associated fetal growth restriction, or if you see subjectively decreased portal venous flow or increased flow in the hepatic arteries, these are all, at least based on our personal observations, are associated with a more guarded outcome. So let me move now to the left brachiocephalic vein. So we're going to go up to the top of the mediastinum. In this plane, we are above all the pulmonary venous system, right? We are right at the level of the mediastinum, and we are looking at this structure right here, the left brachiocephalic vein that connects the left jugular vein and subclavian into this bridge that brings venous blood from the left side, head and neck venous blood, through the brachiocephalic vein to the SVC. And here's an autopsy specimen in a fetus showing you the jugular and the subclavian connecting with the left brachiocephalic vein into the superior vena cava. And this is what you see above the three vessel trachea view. This is towards the top of the mediastinum. You only have the aortic isthmus. I am really at this level right here. You have the IVC, the superior vena cava with the azygos coming in and the brachiocephalic vein dumping into the superior vena cava. So you can have an absent left brachiocephalic vein. That is because you have the left superior vena cava is persisted, so there's no bridge. You can have a dilated left brachiocephalic vein, and I'll show you some example because of the supracardiac anomalous venous return. Or you have an AV malformation in the brain resulting in a dilated brachiocephalic vein. Or you can have an abnormal course that could be inside the thymus, behind the aorta, behind the trachea, in many different locations. So let's look at the persistent left superior vena cava. Diagnosis is based on the three vessel trachea view, showing you an extra vessel. Note the location of the vessel is a bit more posterior than the superior vena cava. Here's the trachea right here. And the blood flow, which is really critically important, if you add color Doppler and you have to fill the both in left and right superior vena cava, you have to reduce your velocity scale and increase your gain. You see that the blood flow is always in the same color because these two vessels are bringing blood towards the heart, and is an opposite color to the great arteries because the great arteries are taking blood from the heart out into the body. So you see clearly here that they are of the same color. That is really critical, and you will know why in a minute. And here's, if you look at the coronary sinus, you see a dilated coronary sinus because this left brachiocephalic vein typically drains at this area right here between the left atria and ventricle into the coronary sinus, as you see right here. And color Doppler will show you blood flow from left to right across this coronary sinus when it is dilated as such. And this is a 3D imaging showing you the superior vena cava coming to the right atrium and the left superior vena cava coming to the borders of the coronary sinus behind the left atrium here. And there's no brachiocephalic vein on top. Now, when you have a persistent left superior vena cava, before you determine that this is a normal variant, you need to look at the heart and do a fetal echo because it is associated with a fairly large number of fetal cardiac malformations, interrupted aortic arch, aortic coarctation, double outlet with pulmonary atresia, and right aortic arch, as you see here. What about an interrupted IVC? So we talked about this in the morning, and you've had several examples of an interrupted IVC. Typically, you see a dilated azygos vein that is bringing blood to the right side of the heart. And this is a classic view called the double vessel sign. This is when you are in a coronal plane of the chest. You see the aorta, and behind the aorta, there's the azygos vein that's almost close in size to the aorta at this level. When you see this, this is always associated with interrupted IVC. If the azygos is dilated, could be the hemiazygos occasionally. Look for heterotaxy and look for left isomerism in that case. And again, here's a dilated azygos, as you see right here. I'm just noting here that the esophagus could be dilated also when the fetus is swallowing. Typically, this doesn't last that long. It goes away immediately if you monitor and watch that carefully. Here's a normal 3D of the IVC bringing blood to the heart and the aorta going down. Typically, a normal azygos is a bit hard to see. And here's a double vessel sign showing you the dilated azygos and no IVC bringing blood into the right atrium. Dilated left brachiocephalic vein, as I mentioned, you see here's a dilated left brachiocephalic vein. This is a plane, again, high in the mediastinum. What are the causes of this? Any AV malformation in the brain will result in that. Here's a vein of Galen aneurysm. and you see the dilation of the jugulars and the carotid veins coming down, and there is a dilated right atrium and right side of the heart because of the AV malformation associated with the dilated brachiocephalic vein. The other important dilation of the left brachiocephalic vein, and that will be expanded on later with the anomalous venous return, is a supracardiac total anomalous venous return. So, clues to the diagnosis here is that the coronary sinus is normal, the left brachiocephalic vein is dilated, and you have 4 vessels at the 3-vessel trachea view. So the coronary sinus is normal, you have a dilated left brachiocephalic vein, and you have an extra vessel at the 3-vessel trachea view, almost in the same location as a persistent left supravena cava. But what is the difference? And if you look at this schematic drawing, this is the supracardiac anomalous venous return. You have 4 pelvic veins draining into this collector vein right here, and then there's a vertical vein that's taking it up to the brachiocephalic to come back into the systemic venous system. The difference between this one and a persistent left supravena cava, this one, the blood is going away from the heart, so you have different color between the supravena cava and this vertical vein, whereas as I've shown you with a persistent left supravena cava, the blood flow is towards the heart, so it's in a similar color as the supravena cava itself. So that's why it's really important when you see an extra vessel to put color on, reduce your velocity scale, increase your gain, to make sure that you can differentiate between an anomalous venous return or just the persistent left supravena cava. Finally, abnormal course. This is the classic course for the left brachiocephalic vein. It borders the thymus gland, as you see right here, and here's the thymus gland right here, and this is the location of the brachiocephalic vein. It could be intrathymic, and this is a common source of referral, actually, because it looks abnormal inside the thymus gland. Here's the normal location right here at the borders of the thymus gland, and here's an abnormal one that's actually coursing in the middle of the thymus glands. Here's this, and this is the aortic isthmus at this level, and this is the supravena cava next to it. And this one is subaortic. You see it's under a right-sided aortic arch. And it could be retrotracheal. This one is behind the trachea, or you can have a double left brachiocephalic veins. Very, very rare. So these are considered to be normal variant in the absence of any other congenital heart disease. And the intrathymic occurs in about 1 to 2% of cases. So putting everything together, your clues to diagnosis. If you look at the liver, look for any dilated veins and any color aliasing. That's your clue to the presence of umbilical vein varix or to the presence of portosystemic shunts in the liver. They all have dilated veins when they are significant, and they have aliasing typically related to that. IVC, if it's interrupted, think about isomerism, think about associated abnormalities. If there's a and then it's associated with dilated azygos or hemiazygos in that situation. The left brachiocephalic vein, it could be absent in persistent left supravena cava, dilated either if you have a brain AV abnormality or in supracardiac total anomalous venous return. And remember, when isolated, if it has an abnormal course, typically this is a normal variant. Thank you for your attention.